Hello, everyone. My name is Austin Parle, and this is my first Journal Club presentation. This presentation is going to be revolving around the patient's dying process from the point of view of family and hospice team, a qualitative exploration of family member and hospice team experiences with hospice in Korea. So, before going into depth on the article itself, I did want to mention the two authors that dedicated some work towards this. The first one would be Soo-Yeon Han, and the other one it would be Yu-Young Yo. Now, Soo-Yeon Han is a licensed clinical social worker and has a PhD in geriatric family studies. She is currently employed as Secretary General at People's Movement Toward Well-Dying, a NGO running for the enhancement of well-dying culture in Korea. Her research is focused on people in the terminal stage of disease. Her latest work consists of expansion of end-of-life care services in South Korea, a qualitative analysis of the experiences of family caregivers and hospice staff. Now, Yu-Young Eo gained her PhD in 2020 in public policy, where she graduated from Seoul National University Graduate School of Public Administration. She is an associate research fellow at Korea Institute for Health and Social Affairs, and her research interests include social services, market policy, long-term care, and so forth. Next would be the goal of study and the hypothesis of this article. For this article in particular, though, I created an implied hypothesis since there wasn't one outright stated within the article. So the aims of this study is to analyze the experiences of family members and hospice teams regarding hospice care in Korea, where culture and institution for well-dying is in the early stage. Now, the implied hypothesis that I developed was that a large percentage of respondents would oppose to life-sustaining treatment. Perception of well-dying and services for preparation of dying process will remain at a low level. This is due to the lack of information and resources, as well as culture for deliberation, communication, and preparation for death not being fully matured. The reason I chose this article in general was because that it related to my service learning that I decided to do. My service learning is at Bridgeway Hospice in Baton Rouge. Bridgeway's hospice mission is to offer specialized care to patients and their families as they approach the end of life. They strive to create moments that matter. Bridgeway Hospice also takes great pride in making a difference in the lives of its patients and their loved ones. They are dedicated to the people they serve, the healthcare professionals they work with, and the doctors and other providers who trust their hospice because of its expertise in care for others. Providing compassionate care to their patients is at the center of their purpose. The reason I chose this as a student was because I felt that this would give me a good opportunity to just kind of widen my horizons and have more experience in other forms of healthcare. Before starting this article, I did want to go over some terms that we should know, and the first one is going to be the paradigm model, which is a significant scientific achievement recognized by a particular community of scientists that provides a model from which springs a coherent tradition of scientific research and also a general way of looking at the world. Now, this article does use the paradigm model to really kind of just put everything together that it gets from multiple sources of hospice care into a discussion and conclusion. We also need to know what the Korea Ministry of Health and Welfare is. Basically, that is the government ministry in charge of the administration of the Act, which shall guarantee hospice service expenses in some or all institutions specialized in hospice care, pursuant of Article 25. And that is just the government policy in Korea that is going to be implementing certain rules for hospice. Some background on this article as well would be hospice care is a division of healthcare that focuses on the palliation of a terminally ill patient's pain. This is done through attending to their emotional and spiritual needs when they are at the near end of life. Hospice care prioritizes comfort and quality of life by helping to reduce pain and suffering. There were a few studies for the hospice team as a unit of hospice care in Korea, and there was also only a few studies focused on the view of family and hospice team for the patient's dying process. So therefore, this study is going to seek and analyze the experiences of families and hospice teams as joint hospice care entities and propose a possible theoretical model that could explain their experience of hospice care through a patient's process of dying with the act, and the act was also implemented by the Korea government. This next section consists of the experimental and design methods. This part is specifically going to be talking about the selection criteria and the process for interview participants. This consisted of personal in-depth interviews that were conducted between September 21st, 2016 and June 27, 2017. The Korean Hospice Association's key personnel were contacted as part of this participation selection process, which utilized the networking sampling technique. The hospice organization sought out the family participants, and at least 6 months had passed since the period of bereavement or grieving, and the participants said they felt at ease taking part in the interviews. They were spouses and adult children with direct hospice service experience, and when recruiting the hospital staff, the type of institution was taken into consideration, which consisted of physicians, nurses, and social workers. And following an explanation of the study's objectives and data collection methods is when the participants could make the decision of taking part in the interviews. This section also talks about the experimental design and methods, but this one focuses on data collection and analysis. So the data for this study was gathered using in-depth interview recordings and observation memos. To lessen the physical and psychological strain on participants, there was 2 to 3 in-depth interviews lasting about 30 minutes each, with approximately 5 minutes in between for a break. The interviews were conducted at coffee shops, homes, or places for work for family members. And then for the staff members, there was a consultation or meeting rooms of the hospice's institution. And this was just to make them more comfortable during the interviews. There was also literature, which included scholarly academic material, books, novels, public hearings, legal provisions that were evaluated in order to create the interview questionnaire. And based on those materials that were studied, there was 3 open-ended questions that were created for the interview. The first being the meaning of hospice care, the next one being the participant's attitude towards the patient's process of dying, and lastly, the participants' experience with physical and psychological changes. So these were the 3 open-ended questions that were generated for the interviews based on the materials that were analyzed. So for each response, they followed up by asking what circumstances or reasonings influenced the participants' remark of changes in meaning, attitude, or behavior. Getting into the first study results, this table is really just going to be listing the fundamental details regarding the participants and their who they were related to the patients, how old they were, what sex they were, and so on. So to basically show this, just kind of explain it. Only case number 2 involves a daughter-in-law. The other cases involve family members with the patient's spouse and daughter as their only connections. And the participants are female between the ages of 30 and 60 and religious or non-religious. The patients, who range in age from 50 to 80, have all been told that they have terminal cancer. Now, 3 doctors, 2 nurses, and 2 social workers make up the hospice team from cases 6 through 12. And their places of employment include inpatient, in-home consultation, and inpatient hospitals. The doctors are experts in internal medicine, family medicine, as well as oncology. The hospice crew consists of individuals in their 30s to 40s. With the exception of case number 6, all hospice team members are female. In case numbers 6, 7, and 9, all hospice team members have personally experienced the loss of a loved one. All members of the hospice crew, with the exception of cases 10 and 12, acknowledge their religious affiliation. And the result analysis of this data produced 133 concepts, 34 subcategories, and 11 categories. According to this analysis process, it creates a paradigm model that can theoretically explain how the families and hospice teams experience with hospice treatment. Now, study results 2 is going to consist of a result of establishing hypothetical relationships and analyzing that data to see the experience of hospice care being classified into 4 types of the level of preparation for death, such as joint type, leading type, refuse type, and late type, and these are all found in Table 2. Now, joint type consists of participants in the shared type of the dying process, cases 1, 9, and 10, claiming that because they began hospice care early, they could begin talking about death in a comfortable manner. The family members claimed that by witnessing the patient's peaceful death, they could accept it and get over their emotional and physical challenges. Looking back on a person's life gave the hospice staff courage in the face of death. As a result, there were a high level of cooperation or satisfaction among hospice teams and families with the care provided. The next type is the leading type, consisting of participants in the leading kind of dying process, which is cases 2, 4, and 8. And they reported that if a patient does not discuss their values with family members in sufficient depth, the patient may be sent to an acute hospital if there is a disagreement among the family members. Therefore, the patient might only remain in hospice care comfortably if the hospice staff can start having conversations about death communication as soon as hospice care is provided. The participants emphasize that pleasant dispositions and doctor consultations enable family members to accept patients' death and decrease their physical and emotional suffering. Now, the refuse type consists of participants in the denied kind of dying process, which are cases 3, 5, and 7, claiming that they made the decision to employ hospice care only when the patient's death was close at hand, and they were unable to make preparations for the patient's death in advance. Due to the patient's condition and the family's strong opposition, the participants had trouble starting the death preparations even though the patient was receiving hospice care. Because they were simultaneously using alternate medicine, hoping for new treatments, expecting improvements in the patient's conditions, and eventually growing weary from depression, anxiety, loss, and exhaustion while facing the patient's death, the participants refused to make preparations for the patient's death. And now we have the late type. And the late type is going to consist of participants in the late stage dying process, which are cases 6, 11, and 12. And this is going to be stating that despite the patient or family member's desire for hospice care, they were unable to use it due to inadequate information about the service, stringent admissions for criteria based on the patient's condition, a lack of hospital beds, and other factors. Even if the patient's qualified hospice care was only on a short-term solution. The volunteers frequently entered and left hospitals while receiving in-home hospice care, and occasionally they witnessed a patient passing in an emergency room. As a result, in-home hospice was a service that the patient only seldom used, depriving the patient's family of the chance to help the patient prepare for death. So for study results 3, it's going to be consisting of the paradigm model above, and it's going to be showing patients' process of dying with hospice care. This is going to be consisting of different conditions that a patient goes through. We'll start with casual condition. This is going to be more of a simplified and summarized version of the article itself in order to make sense of it and just to summarize it. So for casual condition, this is where going to be participants are going to be saying hospice care is a constrained medical service that can only begin after a patient stopped receiving chemotherapy and a primary care doctor asking to join treatment. The next thing you have is contextual conditions, and contextual conditions are going to be consisting of unfamiliarity of the approaching death and a person facing death. And unfamiliarity with death is going to be with patients that are going to be families and hospice teams avoiding talking about death for a variety of reasons in a culture that may or may not accept patient deaths. And then you have a person facing death, which is going to be consistent of depending on the patient's personality, will, and awareness of his own death, and see if he wants to make that decision to potentially discuss that with people, discuss that with his family. And then you have intervening conditions, which is going to be slowly approaching death, death that requires care, or shelter, resting for a little while, and social network for death. So for the first one, slowly approaching death, that one's just going to be participants asserting consultant type hospice teams and may gradually experience individuals' process of dying if they were in an early to assist cancer patients who are not yet terminal. Then you have death that requires care, and this is going to be essentially participants with non-medical care by doctors. And hospice is essential for preparing patients and families to start conversations about death, and the hospice doctors specifically need to assist these conversations. And then the next one you have is a shelter, and the shelter is meaning more for patients who want to go home or they want to return where they came from, and that a hospice is going to have to provide that feeling to them if they are trying to push towards hospice. And then lastly, the social network for death, and that's going to be more of kind of the spiritual experience in the presence of death, and together with doctors and nurses and social networks, the participants said, that the hospice teams, coordinators, stuff like that for patients and their families. And then we have action, interaction strategies, the strangeness of life and death, 60 days of moving in and out. So the strangeness of life and death is going to be talking about like the dilemma of the patient's passing was felt by the participants. Family wasn't able to accept the patient's death, but they did experience a bond that grows stronger with time. And then you have 60 days of moving in and out of time and death. These are going to be like participants that stated that like due to a lack of hospice beds, insurance reimbursements, payments, and more of the financial side of things, that they were unable to really do a lot of hospice care. And then we have consequences, which is a blessing to be able to prepare for death. And consequences is going to be kind of what the end result that we're kind of pushing for, which is going to be the category of effects and, for a mindset to prepare for a decent farewell, looking forward to having, preparing for death, and they could just share that burden and grow more resilient and be more ready for that patient's death rather than becoming unprepared for it. And those are all the things that this parting model shows for the patient's process of dying with hospice care. Now moving on to the discussion and conclusion. The study discovered that the participants received hospice care, which helped patients live out their lives to the fullest without having second thoughts about dying. Hospice care, as they understood it, was the process of assisting with patients' deaths by a variety of measures, easing their physical and emotional suffering. They understood hospice care to be a setting where the patient family and hospice care team can gather to discuss death and create a plan for end-of-life care. Even if they had physical and emotional challenges such as suffering, bereavement, melancholy, they gradually accepted the patient's death into their lives through hospice care as members of the team. Now, the participants' perception of the dying process as a voyage is significant in this study's findings. Going somewhere one never has been is quite terrifying, and the lack of death preparation in Korea culture and the fact that no one has ever died alone are both contributing factors to that fear. Participants also value balanced sailing, believing that different topics, viewpoints should be coordinated, cooperative, and balanced. And this just indicates that a third party who actively assumes the position of mediator is required in order to assist a navigating path. And their perception of the dying process was influenced by a social and cultural norm, as well as how much assistance they received from one another. And however, the study concluded that with the exception of the shared kind of experience, the process of dying for hospice patients was not stable under the new act for the National Plan for Hospice Service. Another thing to note are the limitations that this experiment had. So it should be highlighted that only families and hospice teams, not patients, were interviewed for the study. And the hospice team members were restricted to doctors, nurses, and social workers who are required under the Act. The focus of the study was on terminal cancer, and the families of children patients were unable to be questioned. So the results scope of application is also limited. And future research must therefore broaden its scope to cover all patients covered by the Act. This study accurately reflects hospice care regarding the patient's families and hospice care team. There were many details involving the paradigm model that accurately depicts the obstacles that patients, their families, as well as the hospice care team face when one is facing the end of life. Some of the changes that could have been made or policy implementations were also stated within the article, with the first involving one of the categories of the patients. Now, these, I'm just going to be quick with these. These are just some of the implementation plans and systematic policies that they kind of provided that could help with hospice care. And this also involves the types of leading type and refuse type. So the leading type participants reported that even when a patient chooses hospice in advance, there are times when the patient may be transferred against their wishes to an acute hospital because the family was not fully informed of the decision beforehand. So in order for the family to accept the patient's decision from the start, the hospice team should participate in the conversation about death. And this will just train medical personnel to be able to have those conversations and those communication skills. And then we have another variety of reasons, including cultural taboos surrounding basically informing the patient of impending death and the difficulty of giving up life-sustaining treatments. The participants in the refuse type chose to use hospice only when the patient's death was imminent. As a result, they missed the opportunity to prepare together. And the extent of the care or ability of the hospice team, it was difficult to expect complete care if the primary care physician and the hospice physician's collaborative treatment was subpar. Hence, early involvement by a hospice team that aids in the hospice decisions is required in order to increase the quality of hospice care. And then finally, the late type. Participants reported low satisfaction within home hospice cares as a result of a lack of hospital beds, the use of different compensation after 60 days, and other requirements and other factors. In order to broaden the scope of in-home hospice care, the KMHW must examine the policy plan that might link and expand the long-term care insurance plan for older adults. And these are just some of the systematic policies and implementations that they had and planned for making hospice a better place for end-of-life care. Lastly, this is the article that I referenced in order to give this presentation, and thank you guys for listening.